Hello everyone, welcome back to multi-head slide seminar here in Biopticka. At the beginning, I will announce that the next seminar next week will be cancelled because we organized on-site and online soft tissue seminar, probably the biggest and the best you have ever been to and saw with so many big names having here in Pilsen. It's available online for free, so please go visit our websites and try to register before the meeting. So I've got a couple of cases from various sites. Some of them are, I believe, easy, but educative, I believe. The first case is 70-something old lady with quite a big tumor in her mouth. So it's a lesion mucosa in her mouth, and although the biopsy is not very well oriented, you can see it's squamous and it's something exophytic, something endophytic, and if we go to higher magnification, the squamous epithelium is not very much atypical. It's there are some atypia, but just maybe because of this inflammation there. But do not go to diagnosis of papilloma or something like that, because it's not papilloma, of course. Because you see that at the bottom of the lesion is pushing into the stroma, and the diagnosis is, of course, verrucous carcinoma. So by definition, verrucous carcinoma is very well differentiated, shows no big cellular atypia, and if you just have like very superficial biopsy, you can easily miss the diagnosis if you are not aware about the clinical picture. It's big mass in the mouth. Okay, so the most frequent sites for verrucous carcinomas are head and neck region, oral cavity, skin, especially plantar skin, and upper respiratory tract. Although it shows this papillary architecture, it is not associated with HPV infections. Okay, so never. It's never HPV associated. And the lesion was described many years ago. I believe it's 1948 or something like that, by Lauren Ackerman, very famous pathologist. And before that, it's funny story. The lesion was frequently biopsied, and they didn't know it's carcinoma. They reported it as papillomatosis, acanthosis, hyperkeratosis, whatever. And eventually, the clinician, otorhinolaryngologist, went to Ackerman's office and showed him pictures from the actual patient, and he asked him, what kind of keratosis is this? It's recurrent, it's big, it's obturating, I don't know, oral cavity or larynx, and they agreed that it's bad kind of keratosis, and eventually published probably 22 cases of verrucous carcinoma. So that's the beginning of the story of verrucous carcinoma. Importantly, it's very well differentiated, and almost never metastasizes, should be excised completely, and the patient is cured. So verrucous carcinoma of the oral cavity is my first case. The second case is thyroid gland cytology, and just by it's older lady, just by showing you these clusters of cells, you can easily tell it's malignant, right? So it's cohesive, pleomorphic. And okay, even more pleomorphic, and in some of these clusters you can see these almost samoma-like micro calcifications. So you can tell it's malignant, but the clinical history of the patient is important. We knew that the lady has got something in her gynecological tract. She's after hysterectomy without nexectomy, and the question was, is this a primary tumor or is this some metastatic lesion? In addition, the lady had colorectal carcinoma in her clinical history. So our diagnosis was malignant, probably metastatic, and please check the records and compare with previous histology, because this may be metastatic of high-grade serous carcinoma, I guess. Okay. So otherwise, if no other clinical history, this cytological picture would probably fit into the category of poorly differentiated or undifferentiated thyroid carcinoma. Okay. So our diagnosis is probably metastatic serous carcinoma to the thyroid gland. A third case is a 7-year-old girl, and she's got recurrent ulcerations in her duodenum. You can see here this very reactive looking duodenal mucosa, some debris and fibrin here, and lymphoplasmacytic infiltrate with probably some architectural distortion, but the section is tangential, so I cannot really tell whether it's the architecture is distorted. And the question was whether it could be IgG4 related duodenitis. They asked for it because this girl had elevated levels in her serum in the blood. So we have performed IgG and IgG4 staining. And this is a little bit overstained, but this is always the case with these immunoglobulin stainings. And you can see almost every plasma cell here is IgG positive. And this is IgG4 staining. Sorry. And you can tell that most of these plasma cells again are IgG4 positive. So what to do with that? We've got quite good criteria for IgG-related disease in the head and neck area, in pancreas, in some other organs, but we have no criteria for gastrointestinal tract, unfortunately. And if you go to the literature, you may find that even patients with some food allergies may have raised IgG4 numbers of plasma cells in their mucosa. So my diagnosis is only descriptive, with describing that we have many IgG4 positive plasma cells with IgG4 to IgG ratio more than 40%, which is required for every IgG4 related disorder. And if everything else fits, this is probably IgG4 related duodenitis. And I ask you for the paper, any of these, druhý, tretí. So I will include you 3 papers on IgG4 related GIT disorders. This is one of papers describing duodenal obstruction. In other paper you may found something about recurrent duodenal ulcerations and other stuff in IgG4 related disease in GIT. So the summary of the case is we cannot really reliably do the diagnosis of IgG4 related disease in GIT because there are no strict criteria, and we have to rely on other findings on clinical picture and serology as well. So my next case is a skin biopsy. Again, it's older lady, and it's somewhere from abdominal region, and you can see this basophilic, superficially located, quite well demarcated lesion composed of these bluish basaloid cells, but in higher magnification you can see the second type of cells present. These are these cells with sebaceous differentiation. Okay, so we are dealing with some kind of a neoplasm with sebaceous differentiation. My biggest problem, if I see lesions like this, is where sebaceous adenoma ends and where sebaceous carcinoma starts, because sebaceous adenomas may have quite a lot of mitotic figures, which is the case here. I'm not sure. Yeah, maybe I can show you very high magnification. I believe it's not. I believe it's still a benign adenoma. It's completely excised. I cannot really see cytological atypias here, and the growth pattern is expansile, or maybe it's low-grade carcinoma.
But it's not important because they behave very both.
Agree. Whether it's low-grade carcinoma or adenoma,
when it is extraocular. Yeah.
So, and this is very important information. It's extraocular in localization. So the next step we have to do is to screen for Lynch syndrome variant called Morule syndrome, and in fact the lesion was immunohistochemically deficient for MSH2 and MSH6 staining. So we've got loss of staining, and this is, let's say, suspicious for Morule syndrome. Eventually, most cases, even with MSH2 deficiency, are proved to be sporadic, but we have to recommend the genetic testing, and the patients should undergo genetically testing to rule out syndromic association. So this is extraocular sebaceous adenoma with probably syndromic association. So my next case, again, it's a skin biopsy. Almost 70-year-old gentleman with a lesion in the capillicium. And you can see this very thin epidermis here with crust formation over this malignant looking spindle cell proliferation with many mitotic figures and cytologic atypia, and that's it. It's really monotonous, high-grade sarcomatous proliferation in the skin. So in a case like this, we have to perform lots of immunostains, including cytokeratins, which were negative in this case, melanoma markers, these were negative, vascular markers were negative. The only positive stain was this is smooth muscle actin. Desmin and H. caldesmon were negative. And this is not very specific, but reassuring. This is CD10 expression, so smooth muscle actin and CD10 positivity. And in addition, we've got abnormal P53 staining. And my diagnosis is atypical fibroxanthoma spindle cell variant. Okay, we have to be sure it's not sarcomatous carcinoma, or the most important differential diagnosis is undifferentiated melanoma. Okay, because this is very deadly. If it's superficial and not involving subcutaneous fat, completely excised, it's considered to be benign lesion. Okay. If it goes deeper, it's called pleomorphic dermal sarcoma because the risk of recurrence and metastatic spread it's a little bit higher. My another case is a colon polyp. And we see quite regular, very common Adenomatous polyp with tubulobilose, with low-grade dysplasia. But the interesting thing is here in submucosa, and I will show you first here. We've got some hemosiderin, maybe some smooth muscle bundle, so there are signs of prolapse of this polyp. And this nest here, which looks squamoid or squamous, and indeed immunohistochemically was positive for CK7, P40, P63. And although my colleague who showed me the polyp, he wasn't very sure whether this couldn't be some metastatic squamous cell carcinoma. I believe it's not. It's squamous metaplasia in Adenomatous polyp. This is not very frequent lesion. I never saw any. And I will show you. So this is the latest paper on this entity, squamoid morules in conventional colorectal adenoma. So you should be aware that the entity exists. You may find squamous morules within Adenomatous polyps, and it's completely benign thing, completely benign lesion. Okay. My next case, this is a really nice one. It's a consult case and from Slovakia with preferred diagnosis, which was eventually proven to be correct. And it's a tumor of uterus with metastatic spread within the abdominal cavity involving ovaries and some peritoneal surface. And you can see normal myometrium on the left and the tumorous lesion here. So with this variable cellularity, this fascicular growth pattern, a little bit of myxoid looking stroma. Not that big atypia, but these cells are definitely atypical. And the most important finding here is that we've got plenty of mitotic figures, really many. It's difficult to show them on the scan on a camera, but maybe here in the middle, and there are really many mitotic figures. And the lesion was immunohistochemically positive for CD10, positive for cyclin D1, small muscle actin, negative for hormone receptors, and negative for desmin. And the preferred diagnosis by referring pathologist was high-grade endometrial stromal sarcoma with BCOR amplification or fusion, and indeed by NGS we found this very common BCOR ZC3H7B fusion. So the diagnosis is high-grade endometrial stromal sarcoma with BCOR fusion. These tumors, although the histopathology may not be as striking as in other high-grade stromal sarcoma types, this is really high-grade malignancy, very aggressive one. So the clue to the diagnosis are many mitotic figures, not that typical smooth muscle appearance, and little bit of myxoid appearance of the tumor in the background. And my last case, again, it's quite interesting. This is CNS case. I don't know the exact location, but it's a dural-based tumor. And the case was sent with differential diagnosis of so-called melanotic schwannoma, or it's nowadays called malignant melanotic nerve sheath tumor, and malignant melanoma. So these were two differential diagnostic consideration by referring pathologist. And we can see this spindle cell neoplasm, and maybe with little bit of pigmentation here and there. In the background, you can see there are many lymphocytes. No necrosis was present, and I didn't found any mitotic figure in the whole specimen. So this is a very important clue. And of course, the lesion was positive for melanocytic markers. And because the differential diagnosis was melanoma versus melanotic schwannoma, or malignant melanotic nerve sheath tumor, we have performed methylation profiling, and it came back as melanocytoma. So it's completely benign lesion. So we may have benign and malignant melanocytic lesions on meninges, including benign diffuse melanocytic proliferations and benign melanocytomas, malignant melanocytomas and malignant melanomas. And importantly, there's a category borderline between. So we are not sure in all cases whether it's benign or malignant. So the definitions are written in the WHO classification CNS book. So my last case is meningeal melanocytoma, not melanoma.
So good afternoon, everyone. It's Michael Jr. speaking. I have only 3 cases today. The first one is nothing special, but perhaps more useful for everyday diagnostic work. So this was an older gentleman with a tumor somewhere on his hip, around his hip bone, so in deep soft tissues. And what we got was this very cellular tumor, which was solid to myxoid in most areas. And basically, the first impression is definitely this is a malignant, high-grade malignant neoplasm, most likely sarcoma, but of course you have to do immunohistochemistry to exclude some weird melanoma or some undifferentiated carcinoma. There's a lot of chronic inflammation in the background and scattered highly atypical cells. I mean, all the cells are atypical, but like this one in the center, it's more hyperchromatic and more screaming malignant than the others. So, and also necrosis is here. So what I do in this situation, I do the basic immunohistochemical panel where we have some cytokeratins which were completely negative, some melanocytic markers S100, SOX10, HNB45. I do EMA as a other carcinoma or epithelial marker, and also a marker of perineurial cells, which in this case, I mean, it's not likely to be perineurial, but it's good to have it there. Definitely desmin, and whenever I consider rhabdomyosarcoma as a potential diagnosis, I also add MyoD1. So I also did MyoD1 here, was also negative. Everything I mentioned so far was negative, and definitely in any neoplasm like this, which is older patient with pleomorphic, weird, undifferentiated sarcomatoid tumor, it's good to add this marker. Any guess what this is?
MDM2.
Yes, this is MDM2. So this is I didn't do fish because this is so positive as it can be. So this is almost certainly MDM2 amplified neoplasm in this location. Basically, dedifferentiated liposarcoma is the absolutely number one choice. If it was somewhere close to the heart, you could consider intimal sarcoma. If it was in the bone, you could theoretically think of some osteosarcoma, but those are usually low grade and don't have morphology like this at all. So in this location, almost certainly dedifferentiated liposarcoma. So this is just diagnosis based on immunohistochemistry and compatible morphology, but there are no morphological clues basically for this diagnosis because there are no adipocytes. There was no information that there is a retroperitoneal tumor or anything. So just don't forget the MDM2 in the immunohistochemical panel.
There is a nice paper by Abazagami about Dedif liposarcomas with epithelioid and rhabdoid features.
Yes, this was kind of epithelioid, pleomorphic. So next case, this was very interesting one. It's basically a newborn girl, born in the summer of last year, and she has multiple cutaneous lesions, which usually are few millimeters up to 1 centimeter in size. And we got biopsy from 2 of these lesions. Both look identical. So this is the first one, where you see this myoid appearing. It looks like some smooth muscle neoplasm in the center. You see these bundles of smooth muscle-looking cells with prominent eosinophilic cytoplasm, no prominent atypia, nothing. I will show you the other slide. So this is the next lesion, very similar. Again, smooth muscle-like neoplasm. But the important thing is outside, to notice the population outside of these smooth muscle bundles. It was better visible in this first slide. For example, here at the periphery, you see these darker cells with less eosinophilic cytoplasm. Try to show the arrow. It doesn't seem to work. Anyway, the one in the middle at the very periphery, the darker cells with less eosinophilic cytoplasm. They look more undifferentiated, so that's the second component. So this is basically a biphasic tumor. And then a very helpful clue is this bluish myxoid, chondromyxoid-like stroma. So this basically looks like a myofibroma. Most commonly you will see myofibroma as a solitary adult myofibroma in adults, as a solitary lesion as the name implies. But rarely these tumors occur in a inherited setting, basically. It's called infantile myofibromatosis. And then the patients present with multiple, typically cutaneous lesions. But if it's in this setting, in the congenital setting with multiple cutaneous lesions, it's always very important to do detailed checkup of the patient, because these little kids, very often, in about 1/2 of cases, they have lesions in their viscera and bones as well, and they can be sometimes life-threatening.
Right.
Also in the CNS system, and 10% edited print. Okay, I'll show you one paper later. There is a known molecular alteration in typical myofibromas with PDGFR-B mutations, and these mutations are targetable with imatinib or other kinase inhibitors. So this can be a helpful therapeutic option for these patients. So this molecular alteration was first reported in these familial or inherited settings, and later it was also described in solitary adult myofibromas by Abbas Agaime with our help. We sent there some 20 myofibromas. So now in the WHO classifications, you have myofibromas and myopericytomas classified within one category, because it's basically just a spectrum of one entity. Both lesions typically have PDGFR-B mutations. And the morphology, in our case, we saw in the multi-microscope is typical, and you can see pretty much the same thing here. This chondromyxoid bluish stroma is very helpful clue. It's basically first thing that probably strikes you in the eyes is this smooth muscle-like appearance and this chondromyxoid stroma. If you do immunohistochemistry, I'll show you smooth muscle actin. These lesions are typically smooth muscle actin diffusely positive. It's basically a definitional feature. They have to be smooth muscle actin positive, and they are typically desmin negative or very focally positive. So in the well-differentiated smooth muscle neoplasm, you should have some desmin. In these tumors, in myofibromas, myopericytomas, desmin is typically negative, which is one of the clues that you are not looking at leiomyoma. There is no other useful immunohistochemical marker. So just the morphology. And remember that there is a congenital multifocal systemic variant of myofibroma called infantile myofibromatosis. So my last case, that's the most interesting one. It's a adult male with a tumor on his neck, which was in 2017 diagnosed at our institution as undifferentiated round cell sarcoma. You can see, I think, pretty clearly why. Because it indeed is undifferentiated, monotonous, round to ovoid cells. There was Archer sequencing panel was done back then. It came back negative. So there was nothing else to do. In 2017, we didn't have anything more sophisticated. And because this guy is a friend of one of our employees, we were asked to repeat the analysis with something, some more advanced, more comprehensive panel. So we used the very broad Illumina pan-cancer panel, which detects or can detect fusions in almost 1,400 genes, and we got the result. And the fusion is TAF15 NR4A3, which is the most common alternative fusion in extraskeletal myxoid chondrosarcoma. So the vast majority of extraskeletal myxoid chondrosarcomas, they have EWSR1 NR4A3 fusion, but some cases, few percent of cases can have this alternative fusion. What is important to remember is that these alternative fusions, including this fusion, often present with unusual morphology such as this one. They are sometimes called solid variant of extraskeletal myxoid chondrosarcoma, and has been more and more described in recent years since we are able to basically pick up these fusions and classify these tumors. So in this case, there was very little morphological clue to the diagnosis because it's really just the sheets of small round cells. But in some areas, you can see these kind of like papillary structures, very focally. So that's basically the only thing you can use as a hint. But it's extremely challenging. In this case, it was extremely challenging. I didn't recognize it at all. Here maybe these parts, if you look at them, looks a little bit like some pseudopapillary arrangement. There is not much immunohistochemistry that can be done. S100 is sometimes positive. Neuroendocrine markers are sometimes positive, but just in about 1/3 of cases, and just a kind of focal, multifocal pattern. So you don't know if it's real or not. So really, molecular is the only thing to diagnose these tumors. We had this paper last year or 2 years ago where we had, I think, 2 such cases. Still, even though I was the senior author of this paper, it still didn't help me to recognize it. So this is one of the alternative fusions. It was TAF12 fusion NR4A3. So alternative fusion partner, this was kind of like solid spindle cell tumor with focal myxoid areas. So even more different. And this is case originally diagnosed by Marián Švajdler, which looks very similar to what we saw today. This was just more myxoid in areas, but again, you see this pseudopapillary arrangement. And this case had the same fusion as the case I've just shown, TAF15 NR4A3. Why it's important, this is the best paper on this topic by Xuanying Huang and bone and soft tissue pathologist from Taiwan who will visit us next week as well, and he will actually talk about this very topic. He'll tell us more. You can see they focused on these rare molecular subsets. And this is a beautiful paper showing all, besides the less common morphology as we see here, this is the solid, completely solid presentation, sheets of round cells. This is, I think, undiagnostic by morphology. And what they showed, well, I'm showing it, some of these unusual fusions show rhabdoid morphology. And whenever you see rhabdoid morphology in extraskeletal myxoid chondrosarcomas, this portends a more aggressive behavior. And since the rhabdoid morphology is more associated with the unusual fusions, including TAF15, you can see here cumulative survival of the TAF15 compared to the conventional extraskeletal myxoid chondrosarcoma. The survival of TAF15 is much worse. The patients die much sooner. They often present with metastasis at presentation, and when the patients don't present with metastasis, they seem to fare much better, of course. So this patient of ours, he didn't present with metastasis. He has had multiple recurrences over the years, so hopefully that's a good sign. Good sign for him. Yeah, so that's all from me. Thank you for your attention.
Mycomitis in here. Let's start with something easy. It's a subcutaneous tumor of skin. That we got from Slovakia. And you can see that there are two components, one germinal, which is typical for group of tumors starting with basal cell carcinoma, but others trichoepithelium and trichoblastoma. And second, which is very often neglected, is the stromal. We call the stromal component here, we call it trichogenic specific stroma, because it's seen mostly in these tumors and tumors having similar morphology. You can see even imitation or abortive germ cells. So our diagnosis in this is trichoepithelioma or trichoblastoma. We do not recognize here trichoepithelioma from trichoblastoma. According to Ackermann, was the last one who was having very strong opinion. He distinguished these two tumors, said that trichoepithelioma was more superficial, trichoblastoma more deeper. I think that this the difference is very subjective and impossible to apply to most of the cases. So that we all we call this trichoblastoma mostly in this department. And I just looked very recently. We have close to 1,000 cases of trichoepithelioma and trichoblastoma diagnosed in 30 years. That means it's not a rare tumor. We see it every second week probably, yeah. And we have some genetics done on this, and we are pretty sure that these tumors are heterogeneous group of trichoblastomas that they will divide into several other part of subcategories very soon. Here I have a biopsy of perianal region, and it's biopsy taken from our client. He's gynecologist, so it was easier to explain him what it actually is. But you can see eosinophilic change of superficial epithelium. Then, when you look at dermoepidermal or peripheral epidermal lobes, you can see that there is dysplasia on it, for example here. And in some part we can see we can see that the borders of these bulbs are you can see here that there are beaks on these epidermal bulbs, yeah, and these are typical for incipient microinvasion, yeah. When it is excised in this, well, yeah, you can see it, for example, here, yeah, this beak, yeah, this microinvasive. When it is excised in this in this stadium, it behaves benign way. You can see here very nicely the atypia on the peripheral parts of epidermis, so that we interpret it as a differentiated type of AIN. There is very analog of differentiated type of dysplasia of Vine, vulvar, this molecule vulva, with incipient microinvasion, but what is in this case disquieting is that the dysplasia gets even to peripheral part of it, so that it should be re-excised. And there is another very interesting thing. When we did P53, we got a typical picture that we should get. Proč se to takhle zmenšilo? It's P53, you can see continuous row of cells being P53 positive, which is typical for differentiated dysplasia. For example, here. That means it's the same tumor that usually arises in lichen sclerosus in women in vulva. Yeah? I didn't find lichen sclerosus in this case, but we did P16. And what we find was very interesting. We found in this case very nice block positivity. A very nice block positivity on P16. Even if this block positivity was not well discernible on H&E slides. But when it is P16, we did P16 genetics and we found that there is P16 HPV, there is HPV16 high risk virus. And how to interpret it? We think that the tumor goes to the pathway of differentiated type of dysplasia, this carcinoma, but still it is at the same time there is infection of HPV, and we see it more and more often, and it is very understandable. When you have a patient having lichen sclerosus or differentiated type of dysplasia, this epithelium is much more susceptible to any injury, and then it is much more susceptible to any HPV infection. Yeah, so it's very understandable that you see two lesions, two pathways at the same time, and sometimes even that it's difficult to distinguish whether it's HPV related invasive cancer or differentiated type driven squamous cell carcinoma. This is a tumor of older woman of perianal region as well. And you see it's invasive lesion. Part of epithelium is squamous cell, but part of epithelium is glandular. Yeah. And mucinous. It is what used to be published in the 60s as primary mucoepidermoid carcinoma of anus, but all these lesions are HPV-driven lesions. This is again HPV-16 in women. Yeah. And when you see in a tumor that is having carcinomatous squamous cell appearance, like here, or basaloid, And Adenomatous, admixture to that, you can be 100% sure that it is high risk HPV. Now you can see here Adenomatous differentiation. You can see it here even with brush border. Yeah, you can be perfectly sure that the lesion is HPV-induced, high-risk HPV-induced lesion. We have cases in vulva and vagina which look similar to this but are entirely benign, even in squamous cell component and adenomatous components. I will show you one of these lesions next time. And we found in most of these lesions low-risk HPV. That means HPV-6 or HPV-11. Yeah, so that I interpret these lesions as low-risk HPV-driven benign adenosquamous polyps, yeah, or something like that. These lesions are not well entrenched in WHO classification. And when we speak about these lesions, I should show you one lesion that is in differential diagnosis to it. It's a skin lesion. Which is mostly having basaloid appearance like that. And all of a sudden you see here again, you see here adenomatous differentiation that is rather benign. And you have many of these lesions, and we think that these lesions might be incipient stage of nodular hydranoma, which very often arise in epidermis in lesions that looks like that. We still didn't do genetics. We are about to do it in the coming weeks. Okay, it's all. It's 5 minutes to the end. Thank you for attention. And again, I repeat, next week the seminar is cancelled. And we will see here in 40 days, yeah? Am I right?
Yes.
And please, again, you can connect online to our big 3-day seminar and you can find how to do it on our webpage pathologie.cz. Bioptycka.cz, both of it, yeah. Both of it, yeah. Bioptycka.cz or pathologie.cz, yeah. Both of these webpage allow you to connect. There is over 400 connected pathologists from the whole world. Thank you for attention.